Hi, everyone. This will be the final talk in our series of didactics over LTBI treatment regimens that was prompted by the release late last year of the Washington State Department of Health guidelines on or recommendations on LTBI treatment. I have nothing to disclose. So the objectives today are to recognize when INH is a preferred or discouraged option, to describe the efficacy and safety profile of INH in comparison to other regimens for treating LTBI, and to recognize and manage adverse effects to INH. So here is here are two images of these Washington State DOH guidelines that I just mentioned. Since their release, they've been updated once. The revised versions are from March 27th, and they're available online. If you just simply search in your Google Washington DOH TB, you'll come up to a page and just select LTBI treatment guidance in Washington State. Scroll down, and you can access these two documents. The one on the left is a 10-page document that's not very dense, and the one on the right is our one-page little cheat sheet. So efficacy of INH for LTBI treatment. What is the duration of treatment? For adults, children, HIV infected, is there any difference? No. For all those groups, the recommendation is for 9 months of treatment. And this really came from George Comstock's series of studies in Bethel, Alaska, of Alaskan natives, in which they calculated the percent doses of an annual regimen that patients received, and they looked at the different their efficacy or effectiveness in preventing progression to TB. And what they found is that as you extended the courses of INH from 1 month, longer, through 6 months, you saw increasing gains in terms of TB prevention. But these seemed to flatline around 12 months. And by regressing these lines, they found their hypothesis was that 9 months is that sweet spot, that you continue to achieve gains in TB prevention, but that after that, it doesn't seem like you get much bang for your buck in return. So that's where the recommendations for 9 months of treatment came from. And that was what was first put into the ATS CDC guidelines in 2000. Now, of course, the guidelines also said that if someone takes only 6 months, that's considered adequate for treatment. But the difference in terms of prevention is roughly 6 months gives you about a 60 to 69% reduction in progression of TB, whereas 9 months achieves about a 90% reduction in terms of risk for progression to TB. Now, one of the things about LTBI treatment regimens is most of them, especially the novel ones, have not been compared head-to-head against each other, but they have sort of been compared in that network meta-analysis. This, of course, is except for INH, which typically has been used as the control arm when testing new LTBI treatment regimens. So not only is this talk prompted by the Washington DOH guidelines that came out late last year, but the National TB Controllers Association, in partnership with the CDC, is working on some updated guidelines for LTBI treatment that are in a draft form and have been presented at a number of different conferences. I anticipate that these will be out, released to the public within the next few months. But I did borrow a couple slides from some of Tim Sterling's presentations on this matter. So what they did is they looked at the available evidence in trying to figure out what are the regimens that they would choose to recommend. And this effort was an attempt to balance between treatment efficacy and the risks associated with different regimens, as well as the likelihood that a patient would complete a given regimen. So here we see that in comparing the different regimens available, including daily INH for 6 or 9 months, in comparison to 3-HP, 3 months of daily INH and rifampin, or 3 to 4 months of daily rifampin, that they all seem to have similar efficacy, that is, in a trial, ability to prevent progression to TB. And although it may look like INH is a little bit less efficacious, this is not statistically significant, as these bounds include the point estimates for the other regimens. So all of them are roughly equivalent. You may ask, how can that be when I already just said that 6 months of INH was less effective than or efficacious than 9 months of INH. But again, this is what NTCA in their efforts determined. Now, how about hepatotoxicity? In this situation, it does not seem like they are all equivalent. And in fact, you can see that the INH regimens, daily INH for 6 or 9 months, seems to have higher levels, although it includes the 1 in them. But it seems like there's a trend for higher incidence of hepatotoxicity when you use daily INH compared to the other shorter regimens. So in terms of safety, it looks like the winners are the shorter regimens. And how about completing adherence to regimens? This is a fairly old slide at this point, but I just put it up here to show you that the shorter a regimen, the more likely a patient is to complete it, or the longer a regimen, the less likely a patient is to complete it. So here you see 9 months of INH, 6 months of INH, 4 months of rifampin, and 3 months of INH and rifampin. And we can see that as the regimens become longer and longer in duration, your adherence decreases. And for example, for 9 months of INH, at least in this study, the adherence was less than 50%. That is, less than half of patients that started INH completed a full 9-month course. And I think that this is really borne out in other studies of real-world outcomes, as well as in my own practice, and probably in your practices as well. So putting it all together, remember the NTCA was trying to balance out efficacy with safety and with completion rates. You can see efficacy for all the regimens is roughly similar, whereas INH for 9 months seems to be less safe in terms of hepatotoxicity than the shorter course regimens. And in addition, patients are less likely to complete this. And if you look at this 63 to 76% is actually pretty good adherence to an INH regimen. And I think that's because it comes from these studies. When you probably get outside of the study setting and you look at actual effectiveness, completion rates are lower. And at least anecdotally, are more aligned with that 50% range that I showed you on the previous slide. So INH, why am I even talking about adverse effects after I've spent the last 4 slides trashing it? There are times and places where, thank you though. So there are times and places when you may choose to recommend INH to your patient. So let's discuss the adverse effects. The most commonly seen ones relate to hepatotoxicity, which I'll discuss more on the next slide, rash, which you can see with any of our TB medications, and then neuropathy and mild neurologic symptoms, which are more sort of classic for isoniazid. Neuropathy, what does that mean? That means pain and tingling in the fingers and toes. And it does occur in patients on INH, but far less than 1% of the time. And what's that related to? INH binds pyridoxine, vitamin B6, and increases excretion in the urine. This relates to losses of pyridoxine from the body. So how do you treat it, or how do you even prevent it? Well, you can consider administration of vitamin B6, or otherwise known as pyridoxine, at 25 to 50 milligrams daily or with each dose of INH. Do we give it routinely? Some people do. It's cheap, it's safe. But in particular, the patient groups that you should consider giving it to if they are receiving INH, whether alone or as part of another regimen like 3HP, include diabetics, people living with HIV, patients with renal failure, patients who drink too much alcohol, and malnourished patients. In addition, pregnant or breastfeeding mothers and their infants should be considered for pyridoxine administration. If someone is receiving pyridoxine and develops these side effects, you can consider going up on the dose of pyridoxine, but I wouldn't typically go much higher than 100 milligrams daily. And at very high doses, pyridoxine can cause a neuropathy. Another side effect that I often forget about with INH is rifampin we always think about as driving down the drug levels of many other medications due to cytochrome P450 enhancement. However, INH can actually inhibit a different cytochrome resulting in increases in levels of certain medications. I think the most important ones to remember are these two anti-epileptic drugs, phenytoin, otherwise known as Dilantin, and carbamazepine, also known as Tegretol. What about drug-induced liver injury? You know, INH is metabolized by the liver through acetylation, and it's thought to be those metabolites that have hepatotoxicity. Initially, the drug-induced liver injury, or a DILI, related to isoniazid was thought to be quite a bit higher than this number, on the order of 1 to 3%. That was in part because those studies were picking up patients who experienced what's known as hepatic adaptation. That is, if we checked everyone receiving INH in the first couple weeks of INH administration in a significant number, 10 to 20%, we would see LFT abnormalities. This does not really relate to any injury to the liver or death of cells. I think it's fairly poorly understood, but this typically resolves on its own. And that's why we don't recommend to just routinely check transaminases in all patients receiving isoniazid. More recent estimates as to its toxicity are on the order of 0.1 to 0.15%. That being said, we can identify groups of patients that are higher risk for drug-induced liver injury from isoniazid. I think the most important one to remember is age. That is, as you get older, your risk of drug-induced liver injury from isoniazid goes up. It's uncommon in kids, less than 20 years of age, but it goes up. As you get a little bit older into middle age, it's nearly 2%. Other risk factors for drug-induced liver injury related to isoniazid include patients with underlying liver disease, those who abuse alcohol, who have a baseline transaminitis. So, for instance, someone who has chronic hepatitis B or C but has normal transaminases is not really, we may still check their LFTs, but their risk for drug-induced liver injury from INH is very low. However, if you have the chronic viral hepatitis with baseline transaminitis, the risk goes up quite a bit. And then don't forget about women who are pregnant or have recently delivered within the past 3 months. Those patients are also at increased risk for DILI from INH. If someone develops symptomatic transaminitis greater than 3 times the upper limit of normal, or asymptomatic, if you are checking their LFTs for monitoring, that's greater than 5 times the upper limit of normal, you should hold their isoniazid. What about treatment monitoring? The most important thing to do is to communicate with and see your patient on a regular basis. That is far more important than routine laboratory monitoring. What is currently recommended, in fact, when the CDC has come and examined patients or looked at the records of patients who have developed drug-induced liver injury from isoniazid, the one thing that stands out commonly is a lack of communication. So warn your patient about what the symptoms are that they should be concerned about. Importantly, fatigue may be a cardinal symptom, or weakness. Other ones, anorexia, nausea, vomiting, dark urine, jaundice, or rash. And of course, you want to warn them about potential for neuropathy with numbness or tingling or pain in the hands or feet. As part of this, it's recommended that there be a face-to-face meeting with a healthcare provider at least monthly. Laboratory monitoring is not routinely indicated, but should be reserved for specific groups at high risk for drug-induced liver injury. Who are those patients? People living with HIV, those who drink alcohol on a daily basis or have chronic liver disease, recent transaminitis, pregnancy or recent delivery, and taking medications with potential for liver toxicity. Those patients should be triaged to laboratory monitoring. What's the frequency for that? Well, depending on your concern, perhaps every 2 weeks for the first month or 2 of treatment. Someone's at very high risk, then you may actually go to weekly monitoring, at least for the first month or 2 of treatment. And then in everyone, if someone develops signs or symptoms consistent with liver injury, check the LFTs. So, when should we think about INH? In general, 3-HP or 4-hour preferred. That's the case in the Washington State guidelines. That will be the case in the NTCA guidelines that are coming out in the next few months. But there may be specific patients who have a strong indication for INH. For example, if a patient is a contact to a source case with rifampin monoresistance, uncommon but possible, then INH would be the preferred regimen. For infants and toddlers less than 2 years of age, INH times 9 months remains the preferred regimen. And in fact, on the CDC website, for children 2 to 11 years, they still say that this is the preferred regimen, although in our guidelines, we come down in favor of either rifampin or 3-HP. I think the most common category, aside from patients who have allergies to rifamycins or don't tolerate them, is the patients that have potential drug-drug interactions with either rifampin or rifapentine that's not going to be easily manageable. Who is easily manageable? Well, maybe someone who's on a beta blocker. You can increase the dose of the beta blocker or tolerate a little bit higher blood pressures for the course of treatment. However, someone who's on a protease inhibitor or methadone, for example, where you choose not to provide rifabutin, INH would be the logical regimen. INH interruptions. Remember, if someone develops transaminitis, symptomatic, greater than 3 times the upper limit of normal, or asymptomatic, greater than 5 times the upper limit of normal, you should hold their INH. If INH is held, or if the patient is transiently lost to follow-up or needs to take a vacation from INH, how long do you have to complete treatment? Well, we say if you can get 9 months of treatment, that's based on a dose count of 270 doses within a 12-month contiguous time period, then that's okay. That's acceptable for treatment with INH. If the patient has missed more than 3 months of INH, then we and other experts recommend that you restart INH from the beginning. And remember, if they've missed more than 3 months, it's probably a good idea to recheck a chest x-ray to make sure that they haven't developed active TB in the meantime. So, in summary, INH is administered to almost all patient populations for 9 months. A single dose of 300 milligrams daily using these weight-based guidelines. For lower weight patients, less than 40 kilograms, 200 milligrams may be given daily. Intermittent twice-weekly dosing under DOT is an option. It's listed on our cheat sheet. That being said, it's resource intensive because it does have to be administered under DOT. And so I think it's the uncommon situation in which you would choose this regimen. Regardless, though, it's administered up to 900 milligrams twice weekly for 9 months. For patients at risk for neuropathy, please strongly consider vitamin B6, 25 to 50 milligrams with each dose of INH. Completion of INH is based on the total number of doses, which for a 9-month regimen is 270 doses. And then routine laboratory monitoring is not recommended, but it is recommended for high-risk patient populations. And here's our cheat sheet. Please go to the website to download your own. And I'll take questions or comments or thoughts, disagreements.